Right. I think we can start now, Dr. Ahmed. Hello, everyone. Thanks for tuning in to our talk on AKI in COVID-19. Today we have Dr. Saeed Ahmed. He's a consultant nephrologist and interventional nephrologist at Sunderland Royal Family. He's also the lead for medical services and the lead for the BEMA organ donation in the UK. Without further ado, Dr. Ahmed, I will pass on the microphone to you.
Okay, thank you very much. Well, thank you very much for virtual medical education. This is a talk I have prepared. I need to recognize it's done from the American Society of Nephrology and also colleagues in Italy as well. My name is Dr. Saeed Ahmed. My disclosures are I'm a consultant nephrologist, interventional nephrologist, and a clinical director in the South Tyneside and Sunderland Foundation Trust. It's my great pleasure to do this talk for you today. This is the second time I'm doing it today. I'm having a marathon of talks, and it's very important that you've actually gone second. So I've had a lot of feedback this morning when I did it at 10 o'clock to another audience there. So audience I'm going to assume right now is general physicians. There may be specialists in the audience. I'm happy to take the questions. So I'll do some scene setting, then we'll look at the condition in itself, and particularly I will talk about acute kidney injury, and then we'll come up to the latest data. This is a changing field, as you all know. The pandemic is upon us right now, and the prevalence and incidence is changing. So what I say right now may not be pertinent in a month's time. Okay, so without further ado, so I have to acknowledge American Society of Nephrology, as some of the slides are borrowed from there. COVID-19 associated AKI, and we'll define that recognition and management. Scene set, so we're talking today about SARS-CoV-2 or coronavirus variation 2, and the condition is originally called novel coronavirus, but now we call it coronavirus 2, and then it's COVID-19 as in 2019 when it was first, this condition was described. Now, the condition has a wide variety and variability in symptoms and illnesses. We're now recognizing it not just a lung condition. It's more than that. It's a multi-organ, multi-system condition. There are a small percentage of patients who end up in the ICU. And we are now learning the cytopathic and the neurohormonal mechanisms and also the immunomodulatory mechanism this particular virus affects. We'll talk a little bit about volume status in patients and how different types of volume overload or volume depletion can occur in patients with COVID-19 who have severe COVID-19. And we'll touch on some of the things we are learning about coagulopathy in this condition, where we're seeing different organs have different levels of coagulopathy leading to either thrombosis or mainly or bleeding. That's what we're going to touch on. So let's recap. We're back in Wuhan in around December time, 2019, and research has been ongoing in these coronaviruses for a while. You are familiar with lots of viruses such as H1N1 and the flu pandemic. The viruses traveling through chickens and porcine. Porcine viruses have affected the renal community about a year ago. But in this case, we're talking about this zoonotic infection. So zoonotic means it comes from an animal source. We believe the animal source to be the natural bat, and these are the variations of the viruses on their genome. So it's an RNA virus, which has come from the animal, in this case, the natural bat, and with the intermediate host. Now, compare that to the intermediate host that was in SARS itself, or in MERS, so Middle East Respiratory Syndrome, or severe acute respiratory syndromes. There were different animal hosts, and at the moment, the working pathway is this particular animal called the pangolin, which then was the intermediate host before it moved into the population. And interesting about this particular virus is the infectivity and its fatality rate. So what I mean by that is the cause of mortality in itself. So we believe this may be the root. There's lots of conspiracy theories, but we're going to just stick with the science here, not conspiracy today. So that's the virus. The acute kidney injury we're going to talk about, we're going to define it a little bit first and then see if there's been a difference. So before COVID, so BC, we call it now, before COVID, in different series of acute kidney injury in the ICU, the prevalence rate was about 13.5% in all comers coming to intensive care units. This is a large intensive care society study done a while back, looking at different stages of AKI, and we'll define them in the next couple of slides, but 3 is the worst stage. And out of those stage 3, about 13.5% are requiring renal replacement therapy, not only for support, but also treatment. And we'll touch on what I mean by that. And AKI associated with higher mortality, well, this is well known, mortality and AKI go together in this case. So this was a scene before maybe December 2019. And then we have a number of series, and really we cannot define the incidence and prevalence of AKI in COVID-19 just yet, because the disease hasn't been long enough. There's multiple series. So the rates do vary, and the rates around the world of needing renal replacement therapy in ICU do vary a lot. And we can discuss that in the Q&A. I have some ideas why that is the case. So a small percentage of those coming into hospital, so these are not the asymptomatic or the pre-symptomatic, or the symptomatic well who do not enter into the hospital. These are the unwell people who enter and admitted to hospital during the COVID-19 period. 40 to 60% have AKI, stages 1 to 3. And then maybe when those deteriorate and they end up in the ICU on the renal ward, about 20 to 30% in one series required renal replacement therapy. Now, our local practice and the UK practice is probably not as generous as this, and I know from the national ICU data sets that I've looked at is about 17%. But this is early on in, so we're talking about March 2019 when people started reporting their case series. And again, you've got to remember this in time. So AKI common in hospitalized COVID-19 patients, exactly AKI frequency is not clear to date. Early reports from China, from Wuhan, was very little on to no AKI. But that, and I think that's because their incident rate was high, but the prevalence was low in the sense the lockdown was extreme. And obviously there's always thought about if the data is correct or not, but they didn't see a lot of AKI. Subsequently, Italy, which has a more generous, I think, ICU entrance policy, what I mean by that is case selection, is a little bit more generous. They sort of quite a lot. So 40% of those in ICU and 20% needing renal replacement therapy, either supportive or treatment. And with that, because Italy being a neighbor, the UK government and the Department of Health then start looking at capacity, as we were, as reputed to be 2 weeks behind any other spike happening in Europe. And this is where the whole mantra came regarding protecting the capacity and increasing ICU beds. Because if you have a generous case selection, then you're going to have a lot of people ventilated, and a significant number of them need renal replacement therapy. And these are high intense therapies requiring a lot of nursing hours, doctor hours, and capacity demands is the issue. So early reports here in general hospitals, AKI was 20% and 50% in ICU. And I haven't touched on mortality in these individuals yet. And again, another data set, 20 to 30% ICU COVID-19 cases requiring renal replacement therapy. Now, AKI is usually defined in the first 7 days, and thereafter you get CKD. So let's just define those terms as well. Remember, the recognition is occurring at the front door. So you've got your blood panels, that's straightforward. But we're very keen to spot AKI with normal renal function as well. So what I mean by that is you've got to look for other areas where AKI can occur where the renal function has not changed. And that you can spot by doing simple urine dipstick. I'm very keen as a nephrologist that everybody gets a urine dipstick when they come into hospital. It's not well done usually in most institutes. So definitions. So this is the Kidney Disease International Global Outcomes definition, KDIGO. KDIGO is probably the most up-to-date. And when I talk about acute kidney injury, some nephrotoxic insult has occurred, I'm talking 0 to 7 days. Anything beyond 7 days, we're moving into acute kidney disease, and it has similar stages. Anything beyond 90 days without recovery or complete recovery, then we have different stages of CKD, and we know about the 5 stages of CKD. And these are all based basically on serum creatinine times doubling, so stage 1, stage 2, stage 3. But what a lot of people forget is that there is also criteria for urine output over a 12, 24-hour period that has to be measured. And it's well known in most institutes, it's easier to measure serum creatinine than to measure urine output. Urine output requires a catheter or a diligent patient who's unwell to monitor urine output. So therefore, we don't get those figures well done. And AKD is just ongoing smoldering AKI that hasn't got better and requires renal replacement therapy. So when I'm using these terms, this is what I mean by them: AKI, AKD, and CKD. Moving into the field of coronavirus and AKI, the simple model that we teach is pre-renal, intrinsic, and post-renal, or a combination of these. Coronavirus is interesting. It has an effect both pre-renal and intrinsic renal. And if you look at the mechanisms that are currently now being looked at for coronavirus associated AKI, and you've got to be defining that very clearly, because remember, the normal AKI will still be occurring. So from medications, from volume depletion, from contrast will always be occurring. But specifically to AKI, there's an element of hypovolemia. So this is pre-renal. And COVID high volume, high incident AKI sites reporting concerns of aggressive diuresis. So what we learned early on is that people were worried about fluid overload in AKI associated with COVID-19. And the fluid overload assessment is made on the chest X-ray and the clinical examination. We all know that the COVID signs do occur on the chest X-ray, and we also have an element of pneumonitis causing ARDS. And it's the confusion where ARDS can look like fluid overload, and therefore people are volume under-resuscitated and induced hypovolemia by using diuretics. And we learned that very quickly that wasn't the case. The majority of people are actually volume deplete from the high fever they get with COVID-19 and the ambient fluid losses that they get. We probably do think they are hypovolemic, and so volume resuscitation should be trying to achieve euvolemia rather than to achieve some sort of diuresis. So that's one thing to remember. There's a pre-renal element. There's an intrinsic renal element, so that's affecting the parenchyma of the kidney, and this occurs in two ways. One is something called cytokine storm, and we'll define that a little bit later, or what do we mean by cytokine storms and what are cytokines. And then there is indirect effects such as lung injury, which does occur in COVID-19, causing hypoxia. And then there's obviously ischemia within the kidney as well. Ischemia in the peritubular area will cause significant acute tubular necrosis. Remember, the kidneys are highly oxygen demand site, so they take 25% of your cardiac output. If you're familiar with the kidney, you have tubules. The tubular columnar cells are packed with mitochondria, and they need good oxygen supply. So if you've got a hypoxic environment, you will get element of ATN. And then there's some direct reports here as well, where we've probably got a cytopathic effect of the virus itself. So what we mean by that is that direct invasion of the virus into the parenchyma of the kidney. And we'll show you evidence of post-mortem specimens and biopsy specimens where we have good evidence that there's a cytopathic effect as well. And then other organs may be affected, such as the heart or the brain, but we know there's an effect on the heart. So if you've got reduced perfusion pressure, not only hypoxia, but reduced perfusion pressure that can occur, or people who are ventilated may have a ventilation mismatch occurring, and therefore you also get a reduced perfusion pressure. So that's another way of affecting the kidney itself. And viral invasion, I've touched on a little bit from the cytopathic effect, and we'll come back onto that and how that occurs. So there's about three mechanisms where the kidney can get affected. The one mechanism that I think is not particular to the kidney is we're all recognizing this, especially in the ITU, that there's an increased risk of thrombosis. So procoagulant coagulopathy, there's an increased risk. So here, low threshold for systemic anticoagulation, and we'll touch on the BTS guidelines, which now recommending patients are assessed on a threshold regarding needing VTE assessment and either prophylactic or therapeutic anticoagulation. The ARDS picture is not always due to fluid overload and pneumonitis and leaky capillaries. And there are evidence that the caution with high pressures and the ventilation, it's not my field, but I've been told that the ventilation pressures need to be adjusted. And then obviously high we need to be careful and be cognizant of all the care that we do for ICU patients, from prophylactic anticoagulation to nutrition to achieving euvolemia and to oxygen requirements. So a lot of my talk will be about ICU or just the peri area just before ICU. Now, this is one of the guidances which I alluded to earlier, and I was talking about the BTS, but this is the Emory healthcare guidance on patients who are procoagulant who have COVID-19. So most of our hospitals, we use standardized low molecular weight heparin for those who have never had a VTE before as a prophylaxis dose. But if we start using parameters to assess these patients, so apart from your blood parameters, start looking at CRPs, troponins, procalcitonins, and D-dimers or XDPs, we can then define those patients who are at higher risk and then change their prophylactic anticoagulation. So if we've got a D-dimer less than 3,000, then you might give them a low molecular weight heparin, dose adjust it for obesity and renal function, and then thereafter, when the patient is better, then anticoagulate them with a DOAC in this case. If you've got somebody with no VTE but greater than 3,000 D-dimer, then you go for a higher dose of low molecular weight heparin. You can, on discharge, also anticoagulate them formally for 4 to 6 weeks. If you've had a previous VTE event and you've got COVID-19, then you're going to get a higher dose, which is in this case split dose of low molecular weight heparin whilst you're unwell, but discharge up to 3 months of a DOAC, because we think the procoagulant state stays for that period of time. So this is Emory in the States and their particular guidance. We have similar in the BTS guidance, which looks at using D-dimer. It has a split dosing mechanism as well, and it talks about anticoagulating up to 28 days, not as far as 3 months. So the viewer should be familiar with that particular guidance. So that is different to what you do normally. Everybody gets prophylactic, but this is a little bit extra as we recognize there's a condition of procoagulation in these patients. So what do you do? How do you tackle a patient with COVID-19 and AKI? Well, first things first, you do what we always do and teach for AKI management. You obviously take a history examination, you focus yourself down onto the volume status, and the history examination is classical, but the volume status is important because we're trying to differentiate ARDS with volume overload. And I think early on we thought it was all volume overload, hence the diuretic effect that we saw of hypovolemia. So physical examination, passive leg raises, looking at jugular venous distension, pulse wave analysis, that's normally not available. But I want to focus on this. So point of care ultrasound should be available to you. It might not be in all institutes. If not, then you need to look into it. So we're very keen that people do add this to the armamentarium of assessing difficult patients. And sometimes the patients are difficult due to body habitus or peripheral volume overload, so they may have a low albumin and therefore look edematous, but intravascularly they deplete or they have third space. And in our institute, we are paying a lot of attention to this. And the reason is, at presentation, fever in itself, nausea, vomiting, hyperventilation will give you an element of volume depletion. And during resuscitation in the ED, you'll get a large volume given to you. But we want to be somewhere in the middle, euvolemia. We don't want to be hypovolemic or hypervolemic. And fluid management in AKI is no different. In AKI COVID is no different to classical AKI management, in the sense you take the history, you look for obstruction, so the ultrasound will come into there again when you look to make sure there's no hydrophorosis. You've got a physical examination, and I shouldn't be able. That's straightforward, looking at the pulse, vessel crepitations, edema, JVD or JVP, fever, vital stats, and this is the invasive monitoring is not available in the medical ward, that's ICU, but this non-invasive area, this is where we're going to concentrate on now, because the rest is standard. And this non-invasive, looking at fluid shift changes and looking at ultrasound, is important. And what I mean by ultrasound is devices like this. These are not expensive. If you're in the UK right now, it's a good time for budget holders. You will know that we've got a COVID budget, all of us, that we can use to acquire these. And even if you're not in the UK, then these are not amazingly expensive gadgets to use. So in our institute, we've bought some of these to use for assessment. they're not, then in addition to class examination, they're just an added value which helps us to objectify when you're assessing somebody. And we can train people. This is just a bodywork Eve training simulator we use in our institute to help individuals get used to using ultrasound, and we run scenarios for them so they can look at volume overloaded, volume depleted, look at pericardial effusion, look at fluid in the lungs, all these kind of scenarios we teach. So I'm not saying that we all go out and rush and buy one of these. I said in a trained program, and there are many programs where you can go and get trained on these and get acquired skills and signed off. It's a useful technique to have to in a difficult situation, because even I find it difficult to assess the volume in these COVID-19 patients. Okay, so we've talked a little bit about AKI and the volume status. Let's just look at the epidemiology, pathophysiology, and then general management. I hope I don't need to repeat this. This is probably seen a lot of people know, familiar. This list is not exhaustive. Myalgia, fatigue, leukopenia, lymphopenia. And when I look at the pathophysiology, you'll understand what I mean by that. Obviously, there's history of contact when you do take the history, laboratory, and clinical manifestations of the conditions as they present. Now, you've got to get your timeline sorted, because the patients present with majority, they might come day 7 or day 10 to your institute. So they've had some of these early on symptoms already, and then they will be a little bit better, and then they get the hit with what we call the cytokine storm if they have a dysregulated immune system. So that's worth looking out timeline of their history. If there's somebody coming with just subtle symptoms on its first day, day 0 to 7, then they'll probably just have these symptoms and it gets better. But sometimes they've been isolating for a while, and they come day 10 or 14, they got over that fever, but then they start deteriorating again. So day 10, 14, we've learned that's a type of presentation people come to as well. And this is just alluding to the issue I raised earlier. What is the incidence, and how common is AKI needing renal replacement therapy in the ICU setting or in the nephrology ward? Look, these are the case series up to date from China and the US at this moment in time. There are some more audit data subsequent to this. But look at this case series, RRT for AKI. Here, look, in China is 0.6%, RRT 5.2. But in another series here, we haven't got the figures, it was 22% needing RRT. Overall, it's 5.8. And so this makes it difficult to know how people are labeling these people. But what it doesn't, I think, mention is that there's different case selection of these patients getting to the ICU in the first place, and therefore you have different rates of AKI and RRT requirement. So you just got to bear that in mind. Not everybody gets to ICU. Once you get to ICU, it is those patients with ARDS who are more likely to have AKI. So AKI is, no ARDS is 27%, but if you have ARDS, it's 44% in this series of 8,000 patients. And then if you have here no ARDS, and then you have a cumulative, if you have an ARDS, you're more likely to have AKI, and that's the same figures as this. So both go hand in hand. So therefore, this is the point of multi-organ failure. You will see if you see one, you're more than likely to find the other as well. And these then moves on to what can you do on the ward level, because you're not going to be in ICU. Well, history examination is fine, but why am I stressing the need to look out for dipstick, proteinuria, and hematuria? Because that gives you evidence of the cytopathic element of the virus affecting the kidney directly. So you may pick up here, in this case, there were 710 patients, 44% had proteinuria, 26.9 had hematuria. They could have an AKI was only in 3.2%. So you get far more hematuria and proteinuria than you had AKI. So therefore, the renal function would be normal. You would only spot this if you dip the urine. And again, in a smaller series, proteinuria, hematuria, AKI up to 3.2, serum creatinine only raising 11%. So all of these case series, a lot of them, they do not have a change in the serum creatinine. And that's the way you spot it, because patients are not going to come up to you and say, I've got hematuria, proteinuria. They don't know until you dipstick it. It's usually non-visible, so that's where they will not complain of it. So it's worth dipping that urine because it adds a lot of information. And why do you want to dip the urine apart from adding information and making nephrologists happy? Well, if you've got raised serum creatinine and you've got proteinuria, hematuria, then your odds ratio here of here on this hazard ratio. If it's less than 1, it's unfavorable. Over 1, it means an increased risk of mortality. So very simple. In COVID-19, you have a 3+ of blood, then you've got, there's no crossing of these charts, lines across the midpoint here. Therefore, the hazard ratio is pointing out this increased risk of mortality. 3+ of proteinuria, 3+ of hematuria. Obviously, elevated creatinine, obviously stage 3 AKI, you have more. But very simply, before you've got your use and ease back, if you dip the urine, you've got all that data straight away to allow you to stratify your patient in the rapid assessment unit or the ED or the medical ward, saying this is now going to be a high-risk patient because they've got element of proteinuria hematuria, which is new. You know, we're not talking about existing, it's got to be de novo. And that's why we're keen that you dip the urine. Okay, so that's my little bugbear about that. Let's move on to etiology. AKI etiology and COVID-19, please bear in mind all the other etiologies of AKI, which are we run on a daily basis. This is just another factor on top of that. So common causes of AKI, sepsis, immune function, renal perfusion, nephrotoxic agents, surgeons doing stuff to your bowel, ischemic injuries, comorbidities, heart failure, pre-existing CKD. You put somebody on a ventilator, they might all get AKI due to ventilation issues such as mismatch of oxygen. So that exists, and along comes COVID-19, which then sits on top of that with an extra risk factors. In itself, you need to know a little bit about what I talk about is cytopathic effects of the virus. So just to rehearse, everybody's familiar, it's an RNA virus, it's a coronavirus. It attaches to epithelial cells, such as respiratory cells, and I'll show you it affects not the lung, but other cells in the body as well, through an ACE2 receptor. And ACE2 receptors are on many organs that we're now discovering, and it is this spike proteins here which engage the ACE2 receptor, and then you have a transmembrane protein which allows some cleavage to occur, and then endocytosis occurs within the cell. The cell's host RNA replication mechanism is taken over to create more viruses. In effect, eventually the whole cell dies and the virus is shed. So, and the virus is released again from the host cell itself. So this replication phase occurs in epithelial cells. We know now it occurs obviously in the upper airways, it occurs in the lungs, in the alveoli. I'm going to show you evidence it actually is occurring in the kidney as well, and probably will be occurring in the heart if we looked at it in specimens. So that is the sort of natural coronavirus life cycle. It's replicating. It's actually RNA material in itself. It has no life, but it has to have a host. It has to have a host cell because it requires the energy from the cell to replicate itself. So please remember, it's only infectious once it's inside a host cell. In this particular case of AKI, we've looked at the known causes. I've just shown you that on the infographic. Fluid balance I've touched a little bit on. Interaction AKI-ERDS we've touched on. We're now going to touch on the next 4 elements, which are cytokine storm, is a word that's been used a lot. We're going to define that and what it does in multi-organ failure. The direct effects of, in this case, the cytopathic effects of the virus in the kidney itself. Evidence of rhabdomyolysis and hypercoagulability, and particular types of glomerulopathy that can occur within the kidney. So we've just looked at this particular event here in the epithelial cell of the upper airway. So endocytosis occurs. We have the ACE2 receptor. We have this transmembrane protein which causes some cleavage, allows viral replication, and the virus then causes apoptosis, which means basically the cell dies, more virus is released. Natural immune response would be that you would have some interleukins released, and these are what we call cytokines, and they're released by these kind of cells, T cells, macrophages, and monocytes. And then something happens where there's a divergence of the pathway. Naturally, this is what should happen, that the T cells and T cells in the cells engage with the virus recognition occurs and antibodies are produced. You then clear the virus and you get a healthy immune response. Infected cells are rapidly cleared, virus is inactivated and neutralized, and minimal inflammation occurs. However, in a small number of patients, that does not occur. You get this mechanism. You get dysfunctional immune response, excessive infiltration of monocytes and macrophages and T cells, systemic cytokine release. So these cytokines are then released systemically, and these are a whole group of them. So not just locally in that organ, but throughout the circulation. Pulmonary edema and pneumonia, if it's in the epithelial cells of the lungi, the alveolar cells, and widespread inflammation and multi-organ damage. So we call this crosstalk, which I'll explain a little bit later, where one organ is affected, but through the neurohormonal mechanisms, and in this case cytokine storm, a number of other organs are affected as well. So why does this divergence occur? Why do some people go this way and have a mild illness, and some people go this way and have a severe, or if not life-threatening illness? Nobody knows the answer to this at this moment in time, but there's some early signals. So the ACE2 receptor, this particular guy here, this receptor, is almost ubiquitous, but we know also that several ACE2 protein altering variants in humans can alter interaction with the S protein on the viral spike. So the viral spikes are on the coronavirus, and we know that the ACE2 protein is variable. So the allele is variable, the frequency, so some people have more, some people have less. So there's a variability of that. Is that a signal to say why some people have a variable reaction to it? I'm not sure at this moment, but this is an interesting point. Moving on to a little bit more about the pathology. So we've talked about the ACE2 receptor, we've talked about its internalization and then shedding of the virus, but downstream of that, you get all these effects. You get direct invasion of muscles, so you get the myalgia. You get tubular epithelial and podocyte damage, so then thereafter you get direct ATN, interstitial inflammation, podocytes, microangiopathy, some small blood vessels such as the capillary loops and the Bowman's capsule are affected, and collapsing glomeruli as a result of damage to those glomeruli. On the other side, you get activation of angiotensin 2. You're all familiar with the angiotensin 1, angiotensin 2 pathway, and there's increase, and that leads to this hypercoagulability, which then causes further damage in the kidneys. So clinically, this hypoxia could be ARDS, could be COVID-19, but it could be a VQ mismatch from a PE disease. And similarly in the heart, we may get thrombosis in the coronary vessels, we get ischemia, we get myocarditis. And then secondary sepsis may occur as well. So sometimes you get a bacterial infection on top of the viral infection. But the mechanisms through which, how this occurs through the ACE2 receptor affecting the angiotensin 2 pathway or direct cytopathic effects. We've talked about the B and T cells, and especially the T cells, these myeloid cells, activation of the cytokine storm, releasing all these cytokines. So we think these are some of the mechanisms that the virus will be causing. So not only directly affecting the organ, but systemically as well. And then if you talk to people like Claudio Ronco, who is a professor in Vicenza in Italy, and I'm grateful for him to lending this slide, for particularly the COVID patient with this virus, COVID-19 virus, SARS-CoV-2, this is a kidney down here. The acute kidney injury, therefore, is in 3 different ways. There's the hypercoagulability affecting small blood vessels in the coronary perfusion, causing myocardial dysfunction, which then causes hypoxia in the kidney due to decreased cardiac output. You get pneumonitis. We know that directly ARDS affects the kidney due to hypoxia, and hypervolemia may occur due to increased right heart pressures due to pulmonary congestion. And then you've got the neurohormonal effects through, in this case, T cells releasing all these cytokines, which causes endothelial damage, and then endothelial damage is occurring in the capillary blood vessels. And those 3 mechanisms is how we then realize that the kidney is affected, and what supportive and treatment mechanisms we can do, we'll talk about in the next slide. What we want to do is have the infection in the upper respiratory tract. So this is droplet aerosol related, lower respiratory tract, GI mucosa, and then we don't want to get to the ARDS or this picture where the multi-organ failure and death occurs. And it's somewhere along this, we get activation of T cells, immune dysfunction, and this cytokine storm. So we can prevent this or ameliorate this, then it'll prevent us going to ARDS. Also, the antibodies produced from the T cells lead to this pathway leading to multi-organ failure. So the treatments we're going to look at are going to really see if we can ameliorate the cytokine storm, which is the secondary effect through the mechanisms that we talked about. So let's define that a little bit. What do people mean by cytokine storm? Well, this is diagram of what we think a cytokine storm looks like. You have an organ, at some time point is injured. You have an immune response to it, which is pro-inflammatory, but then is countered by an anti-inflammatory response. Organ dysfunction occurs, but then recovery occurs because of the anti-inflammatory response. And some of this is asymptomatic, but some becomes symptomatic as a pro-inflammatory response gives you the symptoms such as fever, tiredness, myalgia, and then the anti-inflammatory response then controls that. If you don't, you have a control mechanism, this then goes uncontrolled, and you have a huge cytokine response, not only in that particular organ, but systemically as well. So the definitions is a massive activation of the immune system, cytokine storm, extreme release of cytokines, with activation of T cells, B cells, and endothelial cells, and macrophages and dendritic cells, and many other cells, such as monocytes, natural killer cells, and lymphocytes. These cells release these cytokines. So severe, and you will be familiar with some of them. Somebody say, well, these are all very complex, but IL-6 is a precursor to CRP, and you measure that regularly. So IL-6 drives CRP. TNF-alpha, you'll know in rheumatoid disease, and interferon therapies are used, anti-interferon therapies are used in a lot of inflammatory conditions as well. So we're going to concentrate on IL-6 in itself, because that is common to us all. We know what it does. These cytokines, depending on which organ they started off, has a number of systemic effects. So acute lung injury could be an early target with need for ventilatory support. Shock in itself via hypotension, which then needs pressor support in ITU. Altered coagulation due to endothelial damage or due to liver effects itself will cause coagulating problems. Renal failure, we talked about the direct injury as a result of the cytopathic effect as part of a multi-organ failure. And systemic capillary leak, so it's a bit like the alveolar cell I showed. When the cell dies, there's leakage across into the organ itself. So you've got capillary leakage, massive leakage of plasma from the blood vessels into the tissue, causing hypotension. And that's why it makes it sometimes difficult to ascertain if the person's volume overloaded or deplete, because they actually have an internal leak of plasma into the organ as well, which you usually can't measure. IL-6 is the most commonest cytokine in causing cytokine storm. It's produced by B and T cells, causing increased IL-6 are severe infections. So it's not particular to the virus. It can occur in endotoxin infections such as bacterial infection, and they have a number of triggers related to that. Skip over. So when you get release of these cytokines, you get those symptoms, and we touched on those right at the beginning of the COVID virus sort of symptomatology. These are all the symptoms we just looked at. They're all caused by these cytokines. And these are the measurements. So I'm not going to rehearse the symptoms again, you're familiar, but the measurements are quite common. They're not expensive tests. So low albumin, elevated CRP, elevated ESR, elevated LDH, ferritin. If you can measure IL-6, you can do that. But a lot of us have available to us procalcitonin. So the shift we're going to see is a lot of the time is a raised CRP and a low procalcitonin. And that usually helps, and with a raised LDH and a ferritin will give us an idea that this individual is sick enough to have a cytokine storm at some stage. And that's what is in our parameters for assessing COVID-19 patients. I'll move over those. So what do we do in intensive care and in the renal world? Well, we provide support to the kidneys when it's required, but we do a little bit more than that. So I've touched on, this is just a paradigm, infection, viral or bacterial. And this one is bacterial due to lipopolysaccharides. You have a dysregulated immune response and you get organ damage. So along this paradigm, we do different support mechanisms or sometimes treatment mechanisms. So early on, if you had a bacterial infection, we use a different type of filter on the renal replacement therapy. Now, majority of these patients have a viral infection, so we're not in this world. However, we are using anti-cytokine mechanisms. Now, these are variable around the world. Some people are real proponent of this, and there are types of filters we can put on renal replacement therapy techniques which reduce the cytokine storm. And the filters I'm talking about are really either absorption columns like this, so things like hemoabsorption, or we're looking at sorbent columns, which I work like in this particular area. If the cytokine storm is not stopped, then organ failure occurs. Then we support the organ with classical renal replacement therapy, such as dialysis. And there's different forms of that which we'll touch on. So I'm saying to you, we're not only supporting a damaged organ, such as the kidney, but also trying to affect the condition by removing those cytokines. The cytokines are small molecules in these absorption columns or different types of filters. We can actually remove those cytokines. So how do we do it? So here's a cytokine storm in a coronavirus patient. The virus occurs, you get pneumonitis, they deteriorate, they end up on a ventilator in ICU. At that stage, they could be unwell enough that they need total organ support and total body support with ECMO, which is external corporeal membrane oxygenation. So we're providing oxygen to all the vital organs. And that is just supportive mechanisms. What we can do at that stage is put these filters in to remove these rise in cytokines. So hemoperfusion in a continuous renal replacement therapy filter will help remove the cytokines and therefore not allow shock or organ failure to occur. You get endothelial protection and organ support. So that in itself is not proven on RCT, but there are proponents of this around the world which have used this. The issue comes of capacity and demand. It's not available everywhere. And these are continuous, as the name suggests, therapies that are done all the time. The hemoperfusion is done irrespective of time, but is done on maybe once or twice a day over a period of time when the cytokine storm is at its peak. And does it make a difference? The jury is out. There's no RCT to prove this, but people have tried these mechanisms especially in Claudio Ronco's group and in the States, and also down in King's in London. So that's that side. What evidence do I have to say to you that patients have a direct injury to the kidney through a cytopathic effect of virus invasion? Well, here's a post-mortem examination of 26 cases, average age 69, 35% of AKI proteinuria. And what we found within the kidney, so just to orientate you, this is a slice through the kidney. This is one glomerulus. These are tubules. And these are what healthy tubules look like. You have a tubular epithelium. Here's what sick tubules look like, very flat epithelium. And what we're noticing here, this is a thrombus within the glomerular capillary loop. So we see fibrin, ischemic collapse, and capsular protein leaks. And when a protein leaks in the glomerulus, it looks like this amorphous pink stuff on H&E staining on microscopy. If that gets damaged, downstream of this, the tubule will get damaged. So we get non-isometric vacuolation, frank tubular necrosis, loss of brush border, and protein reabsorption vacuoles, which are probably alluded to here. So I'm saying to you that we get an effect within the kidney, first of all, through these mechanisms, where there's blockage of the glomerulus and also damage to the tubules. However, if you look in more detail through electron microscopy, within those tubules, and also the podocytes in the glomeruli, we see virus particles. So these are individual coronaviruses on high-power electron microscopy. And this is in post-mortem. So we now know there's a direct invasion within the kidney. And this just makes nice pictures for you to review. And then, but the scientific evidence is this. The ACE2 receptor that we talked about co-localizes in the kidney in the same area where you find SARS-CoV-2 RNA particles. So here we're lighting up for the ACE2 receptor, and you can find it in the peritubular cells around here. And we can look on special staining on ACE2 as well. And then you can look at the nuclear protein, which is here localizing to the same area. So we've got evidence that it's not just, we're saying, how does it get in? Well, it gets in through the ACE2, just the way it gets in through the lung and other cells in the body. But we can see nuclear protein in itself within that area as well. So this active disease, it's not just that it's arrived there through the secretion in the glomerulus. And this is just another example of collapsing glomerulopathy that you may get. So this blue areas are not normal in this particular patient of 63 who had COVID-19. And again, this is the same picture of that patient, but here's the virus particles. And you can make it out, the spike proteins. These are very nice pictures. We can actually see the cytopathic effect on the podocytes. So we've defined that. We've defined AKI a little bit. We've talked about the cytokine response. I've talked and said about a crosstalk. So what I mean by crosstalk, again, is a phenomenon and a paradigm set by Claudio Ronco. So what it says is you have a damage in one organ, you'll have a distant effect in another organ. And you've got to be cognizant of that. So you get liver, hepatorenal syndromes, cardiorenal syndromes, you get gut-kidney interaction, you get lung-kidney interaction, pulmonary circulation affects the systemic circulation. and you get neurohormonal effects occurring as well. So no organ is independent of any other, and how these mechanisms work, some of them are through immune mechanisms, some are through neurohormonal mechanisms. But you've got to remember they're all interrelated. So that's what organ crosstalk talks about. Okay, let's move into the last bit of the talk and look at management. So we've done a bit about etiology and pathophysiology. What about general management? Look at the fluid overloaded patient. General management is no different to any other management. It's quite a busy slide. So you've got diagnosis and evaluation. So that's based on history examination, ultrasound findings to make sure there is no evidence of obstruction. General blood tests such as a vasculitis screen will be done in most hospitals, have a panel that you can allude to. There are some limitations. You've got to remember all your nephrotoxic agents that you may want to remove. Look at hemodynamic responses as well in the patients to make sure their volume status is assessed well. And then medications that you may give, such as treatment for sepsis with antibiotics, may be counterintuitive at times. And then you've got to look at the indications to call a nephrologist. So the classical things are hyperkalemia, acidosis, fluid overload, which can't be controlled, and then uremia. Now, uremia is less likely, but the commonest thing we're getting called for is volume overload, stroke, acidosis, as a patient becomes sick. Hyperkalemia, yes, is in the classical pattern, but we don't see it as well. Acidosis, we're talking about a pH less than 7.2. And that is from the Acute team in 2019. That's the same for all AKI. What we expect you to do is assess the patient along these paradigms, which is obviously monitoring renal function and considering invasive or non-invasive monitoring. Now, that's easy said, done in ICU, but it's more difficult to do on the ward. So what can you do differently on the ward? Well, you can start looking at ultrasound ways of monitoring volume overload. You can do daily weights, dipstick urines, and assess the patient that way to have an early assessment of urine output. And this is classically done poorly, I'm afraid, because not due to the individual, it's the way we work. In modern medicine, we're not in a continuous environment a lot of the time. We're working shift patterns, and therefore different teams are looking at the same patient at different time points. But those are the KDIGO guidelines of AKI management. I want to just finish on the last bit about a little bit more about fluid balance. So when we are looking after a patient with acute kidney injury as renal physicians, we're usually at this phase. So this time along the bottom, this is presentation. They go through the ED department or the surgical department or maybe front of house medicine department. They're resuscitated. Everybody's volume deplete until proven otherwise, usually. So they have volume given to them, then have an element of maintenance. And it's a few days later when the creatinine is still rising, urine output is dropping, and then the patient is then referred to renal physicians. And at this stage, what we generally find is that the patient is volume overloaded. And I think that is why it's confused people to think, oh, they must be overloaded right at the beginning and we must start giving them diuretics. That's not the case. This is proper management. Yes, we need to think about simple things first, resuscitate them and maintain fluid restrictive and diuretics was the guidance early on in COVID-19. So we're talking about January to March. We felt that a lot of the patients were fluid overloaded. What they were actually was volume depleted with ARDS findings, which made them look as if they were fluid overloaded. And therefore, that's why these restrictive patterns came out, and that's not the case anymore. And the reason we go on about the fluid overload is that if you have fluid accumulation, survival and recovery of kidney function in critically ill patient with acute kidney injury, very simply here, and this is a 10-year-old slide, no fluid overload versus fluid overload. These Kaplan-Meier curves, time along the bottom, shows that if you have fluid overload, then your outcomes are worse. They're very simple. So we just don't want to get into that position. We want to get into euvolemia as much as possible. Patients in COVID-19, if they're presenting early on in their condition, they will be generally volume depleted for this reason. Very high fever, so ambient loss of fluid, intravascular dehydration due to organ mismatch of perfusion of the organ, hypercoagulable states where you've then got no blood flow to certain organs due to thrombosis. And all of these are interacting together. So in general, I think this is the difference in COVID-19 patients. So what we need to do in a COVID-19 patient then is ensure adequate volume status is applied to and gradual net fluid removal. So this is when RRT will start, and we'll start doing this with renal replacement therapy or classical dialysis. So we're not talking about the cytokine storm now, we're talking about fluid removal on patients who are now oliguric or anuric, and they had volume given to them, and they may have an excess volume as well from capillary leak. So renal replacement therapy during ICU surges are really dependent on what's available to you. It's commonly required in life support tools for critically ill patients, but RRT is finite resource due to machines and manpower. So every ICU does something different. In the UK, we have continuous therapies to intermittent therapies. And these are those. So when you go to ICU, you may get a continuous therapy, which is a dialysis machine that's run all the time with a nurse there present all the time, measuring all the outputs every hour. To something in between, which is what we do. So sustained low efficiency dialysis is what we do in Sunderland, up to 12 hours a shift. And then intermittent therapies, which we do on the outpatient program, and everything in between. The issue then occurred in the UK and in other countries. These systems were overwhelmed. And it never occurred in the north of the country, but in the south of the country, in London, we had overwhelming that there were so many patients needed CRRT that other therapies such as SLED or even intermittent therapies or even peritoneal dialysis was done in the intensive care unit because there was not enough manpower or machines to sustain renal replacement therapy. And all of it has been done. And King showed a series of, I think, 6 or 8 cases of COVID-19, ventilated tubed, who required peritoneal dialysis. Thank God we didn't get to that position. We sustained what we had to within the capacity limits we had in the ICUs in the north of the country. And these are those therapies just for information rather than any detail. When I talk about these therapies, there are lots of different terms. So continuous renal replacement therapy is CRRT. You can do CRRT in shorter periods instead of 24 hours, so we call that shift-based. We can do sustained low efficiency dialysis or intermittent renal replacement therapy or periodic, and that's what that stands for. Classical dialysis, which is 3 to 4 hours, and then you can do peritoneal dialysis. Specialized, usually in ICU or nephrology wards. I wouldn't expect this to be done in a general medical ward, but it gives you an idea of what's available. This is just to highlight what we are trying to do. So we're just a cytokine storm, where we have suggested therapies of different types of CRRT, so CKRT or CRRT. Organ crosstalk, where we have different therapies from ECMO to LVAD or CRRT, again, doing at specialist center. And systemic effects. So this is where we do the CRRT continuous or using vasopressors or diuretics or different types of dialysis. So we're trying to not only support, but affect the mechanisms of cytokine damage, organ crosstalk, and systemic effects. So we're trying to do 2 things at once. And people may not be aware of that when we do renal replacement therapy. Last couple of slides. I haven't talked about treatment because I don't think there is any RCT proving treatment. Remdesivir talked about, I could talk about that, but I think the evidence is weak. It does not show curative intent. It shows delay in, well, it shows improvement in return to health by about 4 days in some of the trials, but the trials are not as straightforward as you think. I've just concentrated on this area, cytokine removal, talked a little bit about anticoagulation. So in summary, it's a rapidly growing knowledge regarding COVID-19, high transmissible, associated with high mortality, variability in AKI rates depending where you are in the world, complex pathophysiology, but there's some anecdotal treatments that have worked and there's some compassionate treatments that have been used. My last take-home slide, this is my last slide here, is incident AKI is variable, 0.5 to 23% depending on your treatment and where you are in the world and which selection criteria you have for ICU. Definitely is more common in ICU. Need for RRT is up to 9% across so far. But what can you do? Well, what you can do is in the basic general medical ward or in the ED, assess this bit, urine abnormalities. That gives you a very good idea if this patient has got direct invasion within the cell, if they have de novo albuminuria or proteinuria or hematuria or both. Remember, there's comorbidities associated with these conditions. So if you have any of these comorbidities, hypertension, diabetes, CKD, and CVD, then you're more likely to do worse. And especially if you assess the patient with this, then you straight away, before you've got your lab values back, you are already assessing the risk of this patient deteriorating in your institute. So thank you very much. I hope that was helpful. I'm happy to take questions or clarifications. It was a whistle-stop tour of the talk. Thank you.
Many thanks, Dr. Ahmed. That was a really useful talk there. While we are waiting for the other attendees' questions, I will start the question by asking something about the target for volemia for these patients, because as you said initially, the theory about keeping patients slightly on the dry side is not favorable anymore. Some reports, especially those coming from the Middle East and from Egypt particularly, are recognizing the thromboembolic phenomena as something that is very similar to what happens in acute chest syndrome in patients with sickle cell disease. And they were questioning whether there is a role for overhydration, similar to what they treat patients with acute chest syndrome. Do you have any comments on that?
Yeah, so I wouldn't push overhydration, euvolemia, what I'm pushing, but in combination is the anticoagulation side. So our experience so far is these patients, when they reach needing renal replacement therapy, need a lot more anticoagulation than the regular AKI patient, because they clot off not only the organs, but also the dialysis machines. So we are giving a lot more anticoagulation into the dialysis machine, let alone into the organ in the individuals themselves. And that was an experience we learned from the London groups, because they were losing their circuit so often. And now we had less, because we were 2 weeks behind, we learned from them to do that. Regarding pushing people into a state of diuresis or keeping them well filled, in the controlled environment, maybe, but a general medical ward is not a controlled environment. You will know that it's highly variable, depending on the quality of doctors and the shift pattern and the continuous care that you may get. I think you can do that, and we do that classically on ICU, the prone ventilated patient, where classically the intensive will ask you to dry them out. So we will be doing a lot of renal replacement therapy, putting them into ultrafiltration, removing a lot of fluid. We are just pushing back a little bit. I'm not saying that's not the case. So you can prone them for 12 hours at a time. You put them on inotropes, but we keep them euvolemic. We'll try not to dry them out, as our intensive care colleagues have asked us to do so. So, I mean, we did this talk earlier, so I'm only talking about the kidneys. Earlier on, it was mentioned the multi-organ effect of this. So it's worth, in your basic panels, apart from using these for full blood count, CRP, troponins, LDH, and ferritins, let's talk about if it's available procalcitonin in institute. That's very useful to look at the differential where the CRP is raised and PCT is reduced, or troponins. Now, I have had some pushback by cardiologists who want us to check troponins to see if there's an effect of troponemia in these patients. Practically, it means if you've got raised troponin, you'll be ringing a cardiologist, so you're doing serial troponins. So that requires just a bit of guidance if we're going to routinely check troponins on every COVID patient.
Right, so I've got a question here about from our Facebook page. I think it's in relation to coagulopathy. How did we derive the evidence behind using the D-dimer level to devise what dose of low molecular weight heparin to be given?
So the Emory people use the D-dimer. The BTS doesn't use the D-dimer per se. They look at the previous risk. And again, the evidence base is only on so far experience. There's no RCTs here. The disease has only been around since about November, December last year. So this is based on current practice and national guidance, which is from out in the UK, we follow the BTS to give us that guidance on anticoagulating these individuals. There was a few people doing it. Currently, the RCTs are outstanding to see if it makes definitive difference. But these are guidance followed from the BTS based on experience rather than RCT.
Right, so the next question is about the genetics and cytokine storms in BAME patients. Have you got any comments on that? Does it have anything to do with the concentration of the ACE receptors?
Yeah, so there's all these are theories. Nobody has looked at different ethnic groups, different comorbidities. So you remember early on, there was a panic on the social media about ACE inhibitors and ARBs may increase your risk of getting COVID-19. And obviously a lot of people are on those drugs. And theory goes somewhere like that if you're on an ACE or ARB, then you are less likely to have angiotensin II production. Therefore, the ACE receptors are more available for the virus to attach to and then endocytose in, and therefore you may be more susceptible to COVID-19. So that was a theory that was put out there. The evidence behind that actually is very weak. It seems a plausible theory. There's no RCT, and now counterintuitively, we're seeing ACE or R maybe actually protective in that situation. So there was on a Twitter feed somewhere it came out, and all the national guys from Renal Association, from NICE, and other people in the UK put out that that's not the case, and we shouldn't be routinely stopping ACE and ARBs in especially hypertensive patients. So that's one thing. There may be something in the susceptibility. Now, the cytokine storm, there's so many interleukins, and then to cross-reference those to your phenotype, either your ethnicity or your comorbidities. Yes, there is evidence, I know, when I used to do diabetes research, there are different interleukins released, and dysregulation occurs in those patients. If you're diabetic, I can say that there is a altered immune regulation. As to ethnicity, I am less clear. I haven't seen any evidence saying that you have altered immune regulation. Somebody will be able to correct me who knows more about it. I'm not an immunologist, but you are familiar with the vitamin D story and the association. So people sell this story that vitamin D affects your immune regulation, and therefore that's why it's protective if you take vitamin D. Or converse, which is what we're showing, a low vitamin D is associated with coronavirus infection and deterioration. Not necessarily mean it's the cause and effect, but is an association, and that's how immune regulation may be different in BAME communities who have a low vitamin D level. All again, conjecture and theory, no RCT evidence.
Right, I've got a question here from James Shawcross. I'm not sure if James want to go live and ask that question, but his question is, do you think COVID-19 is a missed opportunity to evidence cytokine adsorption therapy? James, right. You can join in if you just unmute your microphone.
Yeah.
Yeah. It's just we've seen very disappointing results with cytokine adsorption therapy over the years, and there was a huge number of patients who would probably benefit. And I'm just wondering, are you aware of any research out there that that will publish, or do you think it is a missed opportunity?
I think it'll come out in audit data afterwards, because nobody's done the RCT, because that is a very complex RCT to do to make sure you get equal patients in both arms in a condition where there's 50 to 90% mortality, and recruiting those patients. And guess what we did? I think the government pushed out protect the NHS, so the patients didn't overwhelm ICU capacity at any time in the north of the country. It did a little bit in London for a while. It was a shame because we were ready for that, and those patients would then have been enrolled into RCTs looking at difference between continuous therapies or these chemokine responsive therapies. If you believe Claudio Ronco from Vicenza, he says it does make a difference. And he's been pushing this for a good on 10, 15 years. He's shown evidence that CRRT is helpful, but is no better than intermittent therapy. Regarding cytokine storm and hemoabsorption, it's shown evidence that it does clear the interleukins. You can measure them pre and post the dialyzer or the absorption column. Yes, it removes them. Does it affect hard endpoint data such as mortality? There's not shown that benefit. I think if we had all those patients and our case selection was correct into ICU, we'd had a lot more patients on RRT, and then due to RRT being different around the country, we could have done a post-hoc analysis of all the different units. So in where we are in the north of the country, South Tyneside, Sunderland, we have both therapies. In South Tyneside, we do CRRT, whilst in Sunderland, we have slow efficient daily dialysis. I know in Kings, they do the hemoabsorption columns, and other centres they don't. So maybe we would have got a lot of data from that and looked in a registry type way to see if it makes a difference. However, RCT in this present climate, there isn't one right now. Claudio Vicenza's data is all made on endotoxins, and bacterial infections and SIRS type responses in those patients. And he is a proponent for the absorption columns and also the chemokine, response, cytokine response.
Thanks for your answer, Dr. Ahmed. I think it maybe was one of the missed opportunities to, evidence that therapy. But thanks for your answer.
So I think that's it in terms of question, Dr. Ahmed. And we are about 1 hour now. So if you got a few last words.
So I think this talk is timestamped now. It'll change again in another month's time as we learn a little bit more about the condition. It is worth remembering the pandemic and the prevalence is changing. Yeah, and the pre-trust probability of getting a positive patient is less now than it was 6 weeks ago when we were at the peak. We definitely flattened the curve. So the patients are not as common as you think, and we shouldn't be blinkered in naming every patient as a COVID patient. The common diseases are still common, and they will be coming back, such as heart failure and fluid overload and pneumonia. But this is to bear in mind that we'll be swabbing people for years to come now to look for this particular condition. And just be cognizant of that it probably will flatten out, but never go away completely.
Thank you very much. I'm going to send a survey for the session feedback, and I'm going to collect all these results and email it back to you, Dr. Ahmed. Thank you very much.
Great. Thank you very much. Great.
Thanks, everyone.
Thank you.
Okay, bye-bye.
Bye-bye.
Bye.